Good evening. My name is Michael Flynn. I'm a doctor at the Queensland Fertility Group at the Gold Coast. I want to thank you very, very much for being part of my evening this evening. I know from the QFG audio visual that this is being streamed to most of Queensland. So I'd like to welcome everyone from wherever you are in Queensland, but I guess especially tonight, welcome to my local Gold Coast people, and even more especially tonight, welcome to those in the bubble. The border, the people on the border just on the other side of New South Wales who've really struggled over the last little bit, that it's been very difficult to provide services, but our border's been extended today. So we're now able to provide services a little bit further down into Byron Bay and Lismore. And so welcome. I've done these information evenings a few times now, and we've done really quite specific things. We've talked before about egg freezing. We've talked about donor and donor issues. We've talked about using genetics. I've talked about recurrent failure and the really difficult cases. So tonight I thought I'd go really back to basics. The reason why I started what I was doing, which was a long time ago now, but starting to do normal, old-fashioned, we're not getting pregnant. How do I open up the ways and increase my chances of getting pregnant? This is from a presentation we used to give quite a lot in person, but I quite like this as even more personable, that we can sit at home and talk. It's going to go for approximately 25 minutes, 30 minutes. I can see your questions if you bring them up on the side. You're very, very welcome to ask questions. If they're absolutely related to what we're talking about, I'm going to stop and answer those questions. But if not, at the end, we'll have a question answer session as well. So unusually I just talk here, but today I was going to use a little slideshow, and the slideshow we use. So just bear with me for a sec. How we get down, we go share screen, and we go there. And I'm hoping that you see my first slide, and you hopefully probably see me just at the side. And I just want to do one more thing so I can see where I am. That's good. Okay, so the talk tonight is all you need to know about fertility. Actually, I'm going to move one thing there. Fertility is different. I often talk to women and say, if you come in and we have an abnormal pap smear, or if we have an ovarian cyst, we're really good at telling you what has to occur. You need an operation to sort that cyst out. But fertility is entirely different. It's different to what different couples, different people want and expect out of it. And everyone's an individual. And so it's our job more to talk you through all the options, show you how to optimize all of your care, and then it's your job to say what's right for you. Come here. So there's no doubt you know all of this. And if you have all of your choices and you're actually coming and thinking about how to optimize my chances, pre-pregnancy health is very important. It's almost not worth talking about smoking and alcohol. But it is important to talk about vitamins, for instance, and folic acid. And if we are having difficulties with getting pregnant, there are some other vitamins that seem to be more making a difference today. CoQ10 probably helps the energy source within the egg. CoQ10 probably helps the energy source within sperm. Antioxidants like vitamin C probably help. And using a pre-pregnancy multivite really does make a difference to optimize things. I'm not going to talk much more about this because I think everyone who's here tonight and really wanting to increase their chances of fertility is probably on this same page. So the next definition is, what do we think? What's the chances? What's our hope or chances of getting pregnant? And unfortunately, I'm going to be really vague, but most of the times fertility doctors talk in chances per age. And a common age we use a lot is age 35, just because it's sort of in the middle. So I bet you most people, because it's always a surprise to me when I say it to patients, don't really know what their chances are of just having normal intercourse of getting pregnant each month. But if we're age 35, having regular intercourse in our first year of trying, it's about 15%, which everyone thinks as a big shock and thinks back and say it can't be that low. And so it gets to about 85% of chances of getting pregnant in 12 months. And for women under age 35, and there are no other associated features and no other problems, we normally think it's a reasonable thing to try between 6 and 12 months. If there's anything else, if there's pain, if there is other things, then no, we should think about it before then. But all else being equal, we'd probably try for 6 to 12 months if we're under 35. Age is important in how we're looking forward. And those couples where the woman is older than 35, you do start looking at things earlier because you don't want to waste time. You don't want to look back and say, what if? So if we use that definition, that 15% of couples trying regular intercourse and not trying anything more specific than that are not pregnant at the end of 12 months, that says 1 in 6 couples probably need some type of help. And here it comes down to us looking and investigating and what your options are. Are we ovulating? Are we getting an egg each month? Has there been some problem in the past with tubes? Has there been any infection? Is there that process of endometriosis, which is a real problem for a significant number of women? Has there been a male factor or sperm problem in the past? But more and more, the longer I do this, and I was thinking the other day that my oldest baby that I've been able to help or become, or be born through IVF is now 20 years old. The more and more I understand this, there's often a combination of things. It's rarely just a single thing. Is the egg and sperm not interacting easily? We think it's sperm, but is there something else? And then there's this terrible definition of unexplained infertility. And you hate unexplained infertility because all that means is we've got no test for it. There's obviously got to be a reason. So what do we do? In an initial consultation, you go through the whole history and try and say, is there an obvious answer? Let's try and work out and improve health, organize some tests. And the tests we look at are normal pre-pregnancy tests, always do an ultrasound. And a test that you're going to hear about a lot is this test called AMH, the test of ovarian reserve. How many eggs you got? It's very important for us and it's very important for you. And if women have any doubt about the irregularity of their periods and looking to have some reassurance to the future of their fertility, AMH is a great test. But AMH should be taken in context with age as well. I can see questions down the side, and I like interacting and not just being going through lectures. So I was going to look at one or two questions and then go on to what male tests are available. So a question, I've been on IVFs since 2009 with multiple failures. I'm 48. Should I keep trying IVF? I mean, it's a really disheartening question and a very sad story because it just shows the fervor and the importance and what a family means to people that we've tried for that long. And the really difficult answer is that at age 48, with our own eggs, it's very, very difficult. I agree. The main reason often is endometriosis, and endometriosis should be talked about. It's almost like cancer without being cancer, because it's a really difficult, terrible disease. So we'll keep going for next time. What are the type of things that happen that we would do things early to look and investigate fertility? If we've had a history in the past that we might have had a blocked fallopian tube. Polycystic ovarian syndrome is an entire topic on its own, and one I love to talk about. But in essence, it says, are we not ovulating? And is this the reason we're not getting pregnant? So polycystic ovarian syndrome, if we're not having regular periods, is a reason to come in early and sort it out. As we talked about in a really difficult question that I read out before, endometriosis over a long period of time is hard. If women have endometriosis of an early age and we're investigated early, there's a lot of talk and a lot of discussion saying, should we be freezing eggs with women with endometriosis to increase their options later on? Probably in 2009, I wouldn't have talked about that, but now that's really definitely a discussion. And we look at fibroids and are we ovulating? Bring it back to basics. Simple, easy answer with male fertility is mostly just a semen analysis. Men get out of it easy. It's a really simple one. But the reason this slide is up is just to show you that semen analysis can vary. This is a great little story of one lab technician who did his own semen analysis for 120 weeks. Good job if you can get it. Who you can see the variation. So there are definitely times always that semen is a reflection of the last 3 months, and you can be unwell. Therefore, if you've got a single semen analysis not perfect, don't be disheartened. Stay healthy, take vitamins, check it again. We look at sperm in numbers, we look at how well they swim, we look at this process of anti-sperm antibodies, which is probably can't talk about much today. And we look at is everything blocked? Is the sperm outflow blocked, or is it just not being produced? We're individualizing the management of male fertility. So we get all of these things in front of us, and then we can talk about our options. And we're going to see our options in a second. Another question. Had my egg pick up on Thursday, got 7 follicles. I'm guessing that means 7 eggs. Do you think my odds are good? 7 eggs would be probably a pretty average number we'd like to pick up with IVF. The odds depend, unfortunately, on a whole other things as well. Depends on age, it depends on our reasons for infertility. But on an egg pickup, that's a really good number and definitely something to be positive about. So we go through and we investigate and we think the tubes are open, we've checked those and we think we're ovulating, we think sperm's okay. And we've just only been trying to get pregnant for 8 months. Gee, I think the first thing I would do is really explain well the cycle. Really explain well how to use ovulation kits. Really explain well that if we're having intercourse every day or so around ovulation, we're increasing our chances. And a lot of times, just by purely refining those days, it does make a difference. My job's been taken away from me a little bit over the last few years by all the apps you can get on. And most of the apps are pretty good, but they rely on taking the averages of the last few months, because the difference in cycle length changes the day that you're ovulating on. So when you use the apps, you need to use them for a few months first, so you really get a good idea of when it's likely ovulation is occurring. We have honed down on the time to have intercourse. We're increasing our chances with ovulation kits. We're increasing our chances because we're probably using some of the apps, but it still isn't working. Alternative number 2, we're not ovulating. Our cycles are all over the place. That's probably one of the things we like. And I see in the discussion of the eggs we just got, our 6 eggs was age 31. And that really is a good number. That's a great number for that age and gives you an excellent chance usually. But if we're just not ovulating, we'd probably try something simple, all else being equal. There are simple drugs to try and get ovulation occurring. A drug called metformin, Clomid, letrozole, are relatively simple, easy, cheap, and give a relatively good chance. So for women not ovulating, it's more of a step-up process, and you only get to the more difficult things if the easy things don't work. Intra-uterine insemination is my next step up after I'm really confident at home, we've done everything right, or I'm just not confident you're ovulating well and we want to be exact. So intra-uterine insemination says, we will watch and be absolutely confident to the day that you're ovulating, and then we will put sperm inside the uterus on that day. And so intra-uterine insemination takes away the variables. We now can no longer say you weren't ovulating. We now can no longer say that at the day you were ovulating, the sperm was poor. So it increases our chances back to our age chance of success. And so if you go again back to that 35-year-old, intra-uterine insemination probably brings you back to about 15% chance of success. I'm looking at questions again. Another really difficult question, which was almost my entire topic of a talk a couple of months ago, was on recurrent miscarriage. It's very sympathetic. There is lots of reasons for it. It's almost an entire talk to go back. It's the type of thing to see your fertility doctor about, because in the end, things like IVF, which I wasn't going to talk about yet, have the ability to improve your chances. But it's a thing to talk about with a fertility doctor and make sure there are no other reasons for recurrent miscarriage. We do intrauterine insemination for other reasons, of course, and we're doing a lot today with donor sperm, with same-sex couples, with just giving different options for all types of families to have a family. In the end, and working our way all up, we're going to talk about IVF and what it is, because when it really comes down to it, if nothing else works, IVF and this process called ICSI gives our best chance. I'm never going to say I'm guaranteeing 100%, I'm guaranteeing it's going to work, but compared to where we're at and our chances of where we're at, we significantly improve our chances. For definition, IVF is just putting egg and sperm together in a dish and letting it do its own thing. So fertilization occurs on its own. Whereas ICSI, intracytoplasmic sperm insemination, is usually for when there is poor sperm numbers and we think it's unlikely sperm is going to fertilize the egg. And so the scientists, who really are the smart people in our team, the scientists pick out the sperm and put a sperm in the egg. Question, what are the chances of natural conception after laparoscopy? Interesting question. We see it actually more than you would think. And there are different reasons. Laparoscopy, we usually do endometriosis and we clean out endometriosis. So that definitely does improve things. And laparoscopy, we were often flushing the fallopian tubes. And you often think there's little bits of gunk that's flushed out. And so it does. I wouldn't do laparoscopy just for that reason. I usually do laparoscopy for a reason to do laparoscopy. But when we do it, we often do improve our fertility chances. IVF. So what happens? In a normal cycle, without IVF at home naturally, a woman produces one follicle with one egg a month. And it comes out at ovulation time, and we are thinking our chances of success at that point. So how IVF improves success is we use the process of hormone stimulation, which is just injections. It's the part that most women or couples really get tense about, but in the end, it's the part they all are least worried about. The injections are little like pens that you trigger in, and they're like diabetic pens, and they're really pretty simple. So the injections are the same hormone that you produce, but just at a higher dose. So instead of having your one follicle or egg per month, I'm hoping maybe to get 8 to 10. 7 was a good number. So we monitor those by blood tests and monitor them by ultrasound so we can see the size of the follicle and when we think the follicle is ready to be collected, the egg's ready to be collected. It's a specific size. For interest, it's around 18 millimeters on there. So when the eggs or the follicles are the right size, the egg collection, which we can see in the middle photograph there, is just with an ultrasound and little needle guide, and we stick a needle and we suck the eggs out. We get sperm then at that time, and sperm and egg are in the lab, and the fertilization occurs, as we just said, either by normal IVF or via ICSI. The fertilization, we grow the embryos for approximately 5 days. There's always, if we have our 8 eggs, for instance, the fertilization rate's about 80%. So we maybe get 6 embryos. And then after 5 days, as I sort of describe it as a survival of the fittest, we maybe get 3 day 5 embryos, where we would put one in, so an embryo transfer that we're seeing, and we'd aim to freeze a couple more. So hopefully you'd get at least a couple of goes out of one stimulation protocol. So I think you can see that by bringing that sort of 8 months or 8 eggs together and putting an embryo that we know is going and put an embryo that we know is quality, that's the reason that we're increasing our success rates. The questions that are coming along on the side, and we're about to go next, unfortunately are still difficult because they're showing our failure in medicine. And our failure in medicine is that we, as doctors and general practitioners, should be telling all women when they're 20 that age is so important with their fertility, that this is their best chance, and that if there are women who think they're unlikely to have a baby in their 30s, should they be offered egg freezing? And we've had a real failure in doing that as doctors over a generation. And I think this is what we should change in the future, because the questions I keep seeing, and I'm seeing here is if we're 45. And it's 45, the story of having an embryo to implant. There's lots of things that can optimize it, which your doctor would do to optimize your chances of an embryo. But in the very end, the success at age 45 is if the egg and sperm have come together right and the chromosomes are right. And that's the biggest dilemma. Embryos are beautiful. When you just look at this and you see egg and sperm have come in, and the very next day, everything starts to divide. And we see 4 cells, 1, 2, 3, 4. And we see 8 cells. And then we see so many cells. And on day 5, and there's a reason we use day 5 as the day often to put them back in, is because this is the day that embryos want to implant. This is the day it hatches out of its shell. And so blastocyst is our best chance of success. Looking at on day 5, today what has really changed, question from the side that I'm seeing, is in Australia, almost invariably for our first time in women under 40, it would be very, very rare for us to put more than 1 embryo in. It's so important not to have complications with multiple pregnancies that we almost always put 1 embryo in. If we have recurrent failure and if we're doing embryo transfers over 40, there is scope for discussion. But we're always trying to minimize the risk to the pregnancy, and that's why we usually put one embryo in. So, as we were showing there before, I get 9 eggs, 7 of them mature, 6 fertilize, and we're going to get 1 or so to put through and 1 or 2 to freeze. And that would be the normal process. And so usually I'm hoping with 1 egg pickup, we would get 3 goes at it. Embryo transfer, really easy. It's just like a pap smear. You put the pap smear thing in, you slide the little embryo transfer, and hopefully the embryo starts implanting at that time. Whatever's left, we would freeze. And if we're really lucky and we get pregnant with this cycle, when you come back for your next baby in 2 years' time, we thaw that. If we don't work this time, the next month we will thaw that. So freezing is a really important part of the success of an IVF program. We do a blood test afterwards. A little advertisement. There's IVF groups. Queensland QFG, Queensland Fertility Group, was the first group in Queensland. Our part of it was, we've had a unit on the Gold Coast now for 20 years, but the QFG in Brisbane was the first unit in Queensland. It had the second baby in Australia. We belong as a group to Virtus Health, and Virtus Health has the biggest units in Australia. And what that means is, as well as being able to have individual care and say, I can help you on an individual basis, but I have access to some of the best technology because of being in a big group. Technology that it's even hard to talk about at the moment because they're a lecture on itself. But it just gives us so much more access to be able to test embryos and give you options. So we have both our standard care, which is me looking after things. We have a low-cost unit, which is called the Fertility Centre. And we have options for everyone, both in normal IVF care and in all the different things like egg freezing and embryo testing, and it's all there. I'm going to go past that. I was going to talk about success rates a little bit, but the success rates, the bottom line is it is age-related. And I would probably talk about that 35-year-old couple or woman again. And a success rate is around 35-ish%. Most people, as soon as they hear that, think, oh, that's just terrible. But I'm putting it in the context of the people we're doing in it have a chance of natural pregnancy of significantly less than 5%. And we more look at it as, if I get the 3 embryos to use out of this cycle, what's my chances of getting pregnant over putting 1, 2, or 3 embryos in? So that's the process of IVF. I can see a few little questions, and I was going to answer a couple more. And then I've always promised never to go much over 30 minutes because it's a big part of your night, and I'm really privileged that you've been able to join us. So a couple of questions. Pelvic inflammatory disease is frustration for us. The test that's really quite good to see are tubes open or not is usually there's an ultrasound dye test called a HYCOSY, HYCOSY. If the tubes are open, even if we've had some damage, it's a reasonable thing to still just try natural pregnancy because the risk of ectopic is increased compared to everyone else, but it's still not over the top high. If the tubes are closed, then you go straight to IVF. So the normal test with previous pelvic inflammatory disease is something called a HYCOSY. So just for a second, I'm going to get out of there. I'm here. There's a question I sound as though I'm avoiding all the questions, and I'm not. They're the sort of things that, again, are very individualized. And the question is, what are the reasons embryos don't implant? What are the reasons for failure? I guess is a wider range of that. And what are the reasons for recurrent failure? Still, the most common reason that we get a negative test is that the embryo is chromosomally abnormal. And so out of those 3 embryos, if we're age 35, 1 or 2 of them will be normal and 1 or 2 of them will be abnormal. This is the same reason that if we're getting pregnant naturally, we have a chance of miscarriage. And we still have a chance of miscarriage with IVF. There is the ability to decrease that chance by testing the embryo or biopsying the embryo and only putting back a chromosomally normal embryo. And that decreases our chances. So for women who have recurrent failure, that's one of the strategies. The other reasons embryos don't implant are there anomalies within the uterus? Are there fibroids, endometriosis, something called adenomyosis, polyps? Or the other reason that we absolutely know is there, but it's just difficult to do, difficult to treat and difficult to test, is we know that some women produce an immune response. They think their embryo is foreign and produce an immune response to try and inhibit it from implanting. And that's a really difficult one. Well, I'm going to say that I promised that I'd stop at approximately 30 minutes, so I didn't bore you. It's been really wonderful to have your company tonight. We have the ability of with Queensland Fertility Group, anywhere in Queensland, there are doctors up and down to answer your questions. My name is Michael Flynn. I work on the Gold Coast. I'm very happy to be involved, and I enjoy being involved in fertility care, and I get very upset when cycles don't work. I want to thank you very much for your company and hope that this has been of some value to you. Have a good rest of the night. Thank you very much.